Our discussion this afternoon for CAP Fair. I apologize for those following at home for the view. You actually are seeing out of our third floor clinical academic building, so enjoy the view. Focus today on nightclub. You get me, Fight Club. All right? Another one of Meatloaf's masterpieces outside of that at the heliport. Where do you want to go with this? Any particular character you'd like to start?
The narrator.
The narrator, right? So, the narrator. What do you say? So let's keep it simple. What are some things that, if this were reported to you in a clinical setting, might be something you write down, part of your note taking? What do you say?
Insomnia.
Insomnia, right? No doubt.
Like his tendency to go to all these different group therapies, and
How does he get there?
well, he was at the hospital, and I don't remember exactly why the doctor told him. His doctor was like, oh, if you want to feel real pain or something, then go to a support group for people with colorectal cancer or something. Oh, testicular cancer. There we go.
That's where it starts, right?
Yeah, and then so then he goes, and then he has this enlightenment of all these feeling emotions or something, and then he almost gets addicted to that feeling of people listening to you and crying with people, and so it's almost trying to fill that void of something that was present. Yeah. So then he just continues to keep going to all these different support groups.
So I think at the beginning of this film, we have a statement on the biopsychosocial way individuals like us, clinicians, approach behavior in general and mental health in particular, like psychopathology. Remember, he goes to who I believe might be his friend, looks like an EM physician, and I think he requests phenobarb, right? Which is usually our practice. Somebody comes in, doc, I can't sleep, that prescription pad, in a second is out, right? However, this physician, an EM physician, is really up on their knowledge of understanding how to address a chief complaint that would be within the behavioral health spectrum, and that is, I'm not prescribing anything, right? We're going to look at this biopsychosocially, and my first recommendation is going to be psychosocial, more specifically psychological, right? Experience real suffering, and refers to a support group, not for insomnia, which could have happened, but instead, of all things, testicular cancer, right, where he meets Bob. So, that's the first, I think, take-home message here. You are that doc. Now I'm going to put you in a real setting, not that the ER is not real, but a psych clinic. Right? You're in your clerkship, so at least for the next few weeks, you're mine. Psych clinic, chief complaint insomnia. You now know not to reach for your prescription pad first, and instead focus on the psychosocial aspect of this patient's behavior, their chief complaint being difficulty falling asleep, staying asleep, or unrestorative sleep, right? Early, middle, late insomnia terminology. What are some things that you might address first that would fall under the rubric of psychoeducation, of proper sleep hygiene?
You would kind of try to figure out what the association is with their bedroom. Is it somewhere that they do a lot of work, watch TV?
Screens.
Yeah, screens.
Right? So first and foremost, stay in your bedroom. Even if you don't have time to go into deep diving into their experience, you could jump right to the end of this. Stay out of your bedroom. The bedroom is only for sleep and sex. I don't want you doing anything else in your bedroom because I don't want you associating that room with wakefulness, right? By the way, what form of learning might have occurred that is significantly influencing insomnia if that were to occur?
Classical conditioning.
Yeah, maybe there's now again, you're not going to get into discussing classical conditioning with them. You're going to break it. You're going to simply say, don't do it, right? So, out of the bedroom. Anything else?
Do they drink coffee?
Like me?
No caffeine. Not cut down. Of course, harm reduction. But you have to be very clear. The goal is no caffeine. Here's a general idea. You're coming to me for help. And my recommendations are going to be staunch and direct. I need you to purge your brain. Okay? I want to cleanse. And the best, if we ever have to get to medication, the best chance that medication is ever going to have to work is a CNS that is clean. So let's have a goal. As a goal, no caffeine. All right. Now I understand this may actually induce withdrawal, which itself is a clinical syndrome that we have to address in the treatment plan, but so be it. That's our goal. Right? Let's really purify this. I touched my head. Brain. No caffeine. What else? Oh, by the way, that includes quote-unquote hidden caffeine. Online, there are multiple resources. Which food has the highest density of caffeine?
Chocolate.
Chocolate, yeah. So be very careful. They meant to give up coffee, but if they're sucking down those chocolate bars, they're not following through with their treatment plan. So, what else?
Exercise.
Yeah.
Alcohol and exercise. All right, so exercise, yes. Your recommendation for exercise?
I wouldn't want it done within like 4 hours-ish of bedtime.
Yeah, nothing after 5 or 6 p.m.,
Yeah.
assuming that they work on proper shift. And Doc, how long, how frequent?
In terms of their exercise regimen, I'm not quite sure in terms of sleep exactly, but I just like a general lifestyle modification. I'd want them to working out like 4 or 5 times a week, like for 60 minutes or so.
Yeah, 30 to 60 minutes, 5 times a week, American Heart Association. Now, if you really want to get specific, you could talk about their the basal heart rate, etc. As a shrink, as a psychiatrist, I think giving them how frequently and how long is a start, right? And not after 5 p.m. I don't want you winding down with a rigorous workout every night. That's counterintuitive and it's going to be counterproductive. No alcohol. Okay. What if there's difficulty? Doc, you said that for caffeine, I should do A, B, and C because of potential caffeine withdrawal, and so you list that on my treatment plan. Should we also list the potential of me having difficulty stopping alcohol? Not withdrawal per se, but having difficulty. How could I address that? And the hint is, how would the ER physician, the ED physician, address that?
Are you
Like
talking?
a-
Go ahead.
Sorry, just like a clarifying question. So like in terms of they want to stop drinking, but
Exactly right.
so like medication, like
Like naltrexone
or
How would the ER physician in this movie,
or
what would his answer have been?
Would he try and
Okay,
clarify how much he's drinking to begin with?
No. But yes, but no.
disulfan?
Huh?
Disulfan?
No, he didn't reach for the barbiturate.
You would probably
He didn't reach
say
for the script.
Go to like a meeting. And
What meeting?
Oh, AA. Go to AA.
Hey, I'm not an addict. Your answer.
Well, there are people who are struggling with their dependence on alcohol of all different levels, so you could just learn strategies in here from different perspectives.
There's a single criterion to attend an AA meeting, and this goes for NA as well. What is it?
Want to stop drinking?
Yeah, desire not to drink. The addict, the pregnant woman, and our patient, equally invited to AA. All right, so let's put the kibosh on the myth that you have to drink daily to attend AA, that you have to be an addict to attend NA. Nope. Desire not to drink or use gains you admission. So please consider that to be part of your treatment plan, in as much as you're letting them know that your medical recommendation is no alcohol. No alcohol, no caffeine, no bedroom. Exercise. What else?
Isn't there like another recommendation of like if you try to fall asleep and if it doesn't happen in like 20 or 30 minutes and just like don't try to force yourself to sleep in the.
Let's talk about that next. That's going to be step 2.
Okay.
Step 1 is proper sleep hygiene. Anything left in step 1 before we get there?
Screen? Screen time?
Yeah. And that goes to that little screen in your pocket too. Right? So be very careful about that. Right? And generally speaking, that kind of folds into taking inventory of your bedroom. I mean, it seems intuitive, but it's not always that your bedroom is quiet, it's temperate, it's comfortable, and it's dark. Right? So pay attention to that.
Is there also another one of like trying not to eat right before bed?
Yeah, no eating. Yeah. And no drinking either, not only alcohol, but anything. Because if you're getting up in the middle of the night, you have nocturia. That can be disruptive, especially if you have middle insomnia. Yeah, so no eating or drinking at least 2 hours prior to bedtime. Doc, I have to eat because the hunger itself will keep me up. Isn't there something that if I have to, you'd recommend? Answer? Something that is not going to be high in carbohydrates or instant energy. Something that does contain serotonin. And something that is calorie dense where not a lot of it is going to be filling.
Seltzer.
As long as you don't have a peanut allergy.
Drink water.
Or peanut butter?
Yeah. Yeah, a couple of tablespoons of peanut butter often does the trick. If you have to. Anything else for sleep hygiene?
Like, I don't know if you have like anxiety or like racing thoughts or like other things. I guess that's less hygiene, but like none of that's gonna work if
Yeah.
you have other things.
Doc, I've done everything you've asked, and I still can't sleep. Next step is behavioral modification, right? So the idea here is to focus on sleep efficiency. That is, the time sleeping divided by the time in your bedroom approaches 1. Okay? And how do you get that ratio to approach 1? Said before.
Like if you can't fall asleep for more than like 20, 30 minutes, then just like try again. Like you get up and like just do something.
Exactly right. You're in that bedroom for 20 to 30 minutes and you're still up, get up and leave the bedroom. When you're tired, again, go back to bed. If 20 minutes later, 30 minutes later, you're still up, leave the bedroom. They will spend a large part of their first night walking back and forth between their bedroom and their living room. And they might call you the very next day telling you you're the worst physician that they've ever encountered. Their sleep efficiency log will clearly show that. But what it will also show is that if they persevere over time, they'll actually get much better at this. And that ratio will approach 1. Which leads you to tell them, reassure them, and this is where you have to reference this, I actually made this up, that a good night's sleep does not happen overnight. Right? It takes some time. I said that once to a patient, like, oh. That was when I was a resident, a long time ago. Sleep efficiency. All right? Now, hey, doc, when I get up, what should I do? Read a book.
No
Okay?
screen time.
Huh?
No screen time. No screen time. Like
No
so
screen,
much-
that's exactly right. No screen time. The bottom line here is do something boring. So let's talk a little bit about what your hobbies are and what you consider to be boring. When you talk to patients about this topic, there's one thing that tends to come up characteristically. So if they want any ideas, what might you recommend to them? Folding laundry. Right? Very few people will tell you it's exciting. Right? So be careful of the book you choose. All right? And that's where you get to individual differences. So you have to have a conversation about this, but across multiple conversations, folding clothes seems to be a fairly unanimous pick. So an insomniac, our narrator, should never be folding his laundry during the day. Always leaving it tonight. All right? And if you have a partner that folds your laundry for you, let them know to stop. You'll do it.
They can do the dishes.
Yeah, I was gonna say. I'm
They can do
looking
the
at
dishes
dishwasher.
or something more like stimulating. I don't know.
What is it?
They could wash the dishes
Dishes.
instead. Something more like, I don't know, stimulating. I feel like
Well, if you get the water hits you, you might, you
Or
might
under
actually
the
experience a
dishwasher.
stimulator.
yeah.
You trade off chores, tasks.
I don't think so.
All right, doc. Behavioral modification didn't work. What's step 3?
Medication?
That's step 4.
What'd you say?
That's a medication.
Oh, medication.
CBT.
Yeah. Formal referral to psychotherapy, and the psychotherapy that I think has the most empirical evidence is going to be CBT. And that's where the racing thoughts comes in, especially the automatic thoughts. People have their head hit the pillow, and they're up 5 minutes, and all of a sudden the automatic thought is, here we go again. When you hear a patient during your interview say, if I don't get my 8 hours, I can't function. Those automatic thoughts, that catastrophizing needs to be challenged in a therapeutic setting. Refer to CBT, right? So number one, always review proper sleep hygiene. As a primary care physician, you should be doing this anyway, even absent any chief complaints of insomnia. Number two, when sleep hygiene alone is unsuccessful, behavioral modification, keep a sleep log. When that fails, number three, a referral to CBT, and if that fails, go to what will often be in a textbook or a shelf exam, the judicious use of medication, right? Now, let's talk a little bit about the word judicious. A nice practice to incorporate to make sure that your prescribing is in fact judicious is telling your patient what the plan is before you pull out that script, before you actually write it. And that is, we are going to stop this medication on this date. That's the plan. So in between now and then, this is what we have to do. If you haven't already seen your CBT therapist or you've fallen out of therapy, we need to look at that. If you don't have a plan, do not pull that script out in the first place. Because 9 times out of 10, what will occur is that a month, 6 months, a year later, your patient will not have made any gain, will not have made any improvements, and you'll still be writing their scripts for them and very likely be at a higher dose. You're going to be really behind the 8 ball. And now you have another problem called dependency. So as to avoid that, have a plan in the beginning. And if not, just let your patient know that until you do, we will not be prescribing medications. You prefer to continue with the current plan, which is largely behavioral, that is psychosocial. Questions up to this point?
Would you count the use of like melatonin as like a
That's my
pharmaceutical
first
or-
choice within step 4.
Oh, okay.
Yep. That's my first choice within step 4. Now, the other part of this that has no real anchor in any of these steps, but should have taken place way back at your initial visit, is to always evaluate for co-occurring illness. So if the insomnia is part of a larger disorder, please identify and apply FDA-approved treatment to that primary disorder, which is going to get us back to what is Fight Club really about. So he's presenting symptoms of insomnia. Are there any other behaviors that caught your eye?
Seems like at work he really has like derealization or like depersonalization a bit. He's kind of outside of it. He hates the corporate structure, like normalcy.
Yeah, I would say definite portrayal of depersonalization. He seems to be disconnected from himself. I think that's fair. And probably even an element of derealization as well. That is a very similar subjective sense, albeit pertaining to his surroundings. So that's a consideration. Now, we have a condition called derealization, depersonalization disorder. Had it backwards. Depersonalization, derealization disorder. And if we don't feel as though these feelings are part of a larger disorder themselves, then that might be our single best diagnosis. So that's something to consider here. As we're considering this, there are 2 things that really are going to be at the very top of our list to consider. That is choice A, and choice 1 and choice 1B. What are those 2 things that, now that we're looking at co-occurring conditions, rule out depersonalization, derealization disorder that we must consider?
Dissociative activity.
DID.
Depression.
Schizophrenia.
Number 1.
Substance abuse.
And 1B?
Like due to medical illness.
Always. Because before you discuss anything with your patient and begin prescribing medication, if an occult medical condition then manifests, boy, are you in trouble. Similarly, if you subjected them to a treatment plan that includes medication, when this was all substance-induced and you could have removed a noxious stimulus to improve their condition instead of adding to the situation, you're talking liability here. So always rule out organicity. Any evidence here in this movie that our narrator is afflicted with either of those?
I don't think you could rule out substance-induced. I mean, he does ask for the benzo, or I forget, bar pretty specifically, so he's at least familiar. And I think that there's not like definitive evidence against it. It's just kind of given some of his behavior.
Well, I think it's fair.
It's definitely possible.
There's something to investigate here. Now, again, he could have just did it because he did it. But as a psychiatrist, you don't ever leave anything up to chance or coincidence.
Yeah, I'd want to UDS on him at a minimum.
And patient history. What have you tried recently? What have you experimented with? What have been the effects, etc.? Cage questions. If you were to focus on a specific class of drug that might be high in your differential, that is, let's say that in your hospital, the urine drug screen was limited and you had to actually call the lab to alert them to what you're suspicious of. What's number one on your list in that UDS?
LSD.
Yeah, hallucinogens, right? So what are the three classes of hallucinogens?
Like stimulating.
In body? No.
I think it was LSD.
No, that wasn't.
What movie is in it? What entire movie is an LSD trip?
Alice in Wonderland.
Yes. And the most modern and best adaptation of Alice in Wonderland? Sequel just premiered?
The Matrix?
Yeah.
Oh.
LSD. The second subclass of hallucinogens are the deliriums. Obviously, they make you confused, delirious. Anticholinergics, antihistaminics, easy examples. That includes anticholinergic medications as well as those with anticholinergic or antihistaminic side effects. So Benadryl, example. Side effect. Remeron, mirtazapine, an example, right? Especially at low doses. We just discussed that this morning. The third and final subclass of hallucinogens are your dissociatives. So that's going to be really at the top of your list. Give me an example of a dissociative medication or drug.
PCP?
PCP?
Or bath
Bath
salt?
salts?
Yeah. Bath salts are stimulants.
Oh, really?
Yeah, they're officially stimulants. Dissociative, yes. So they still, yes, dissociation is a major untoward effect, but a stimulant class. Within the hallucinogen class, the best example would be PCP and its analog ketamine.
Where does shrooms fall into that?
Psychedelics. Yeah, psilocybin is similar to LSD.
Okay.
All right. Any questions about, or let me ask you, any evidence that any of these subclasses are playing a role here? Other than the obvious dissociation.
PCP, are you prone to violence and
Yeah.
irritation, and given some of the
Yeah.
rather violent bursts that could
Absolutely. Yeah, PCP.
I mean, you don't see nystagmus, but I mean, I'm not really looking for it either in a movie. But
Yeah, and I don't know if
it's not an obvious. Right, but
Yeah, how great would it be though if you got one close up and you look, and there was some fluttering in that pupil? How awesome would that have been? Fincher would have been all over that. So PCP, untoward effect, aggression. Another movie that might be indicative or representative of acute PCP intoxication, 80s film. Despite the fact that it was...
Taxi Driver?
Well, that's possible. I got even one better than that. The Terminator. Right? Don't do this now, but if you Google Terminator police station scene, all right, and watch, that's the scene that begins with the tagline, "I'll be back." All right, so Schwarzenegger leaves the precinct, and quickly you see Reese and Sarah with two detectives, well, actually, a detective and a psychologist, and they're trying to convince the detectives that they're being persecuted by a cyborg from the future. Right? By the way, choice A, mood, anxiety. Choice B, psychotic dissociative. What would the psychologist in that scene think?
Psychotic?
Yeah. So clearly Reese is the one promoting this. Sarah's going along with the story. What diagnosis might that suggest?
Folie à deux.
Folie à deux. Next step on your exam.
Interview them separately.
And what happens in the movie? They
I
separate
haven't seen
them.
it in a while. Yeah.
They separate
I
them.
haven't seen it.
Now, the psychologist, the expert, stays with Reese. They identify Reese as the proband case. Sarah goes, or is with the detective. And as she is away from Reese, who, by the way, is like almost literally crawling up the wall. You know, you people are all going to die, right? He's off his rocker. Sarah's calmer. Right? Sarah Connor gains some insight and tells the detective, does sound crazy, insight. But, you know, I saw it myself. I saw this man put his fist right through a windshield. What's the response of the detective?
I know that must have been disturbing. for
Huh?
you.
No. That psychiatrist would have said that. The detective doesn't reassure and reflect the feelings there now. Says it's probably PCP. It's actually in the dialogue. Seconds later, what happens?
Does Arnold come back at that point
How does he come back?
with the car?
Right through
Yeah.
the precinct wall. And with the exception, of course, Sarah and Reese, who escape, kills everyone in that police station. That is a great depiction, fictional, of acute PCP intoxication, specifically the psychological or behavioral effects of that substance. Belligerence, assaultiveness, irritability, and aggression. I mean, it's picture perfect. The other part of this, for all hallucinogens, PCP now as an example, is that there are also physiologic sequelae of acute intoxication. If you look at the DSM, you need to rearrange the diagnostic criteria. But you mentioned nystagmus, right? The one that you'll, I think, see on exams a lot is Rotary Nystagmus. That is a diagnostic criterion. And if you rearrange those criteria, it actually spells out the word Terminator. So I'll post that on Instagram later today for you. I don't have to review it right now. But watch that Terminator scene. You'll never miss identifying acute PCP intoxication in a clinical vignette on your shelf. Right? Both behavioral and physiologic. All right. And we see some aggressiveness and belligerence in the character as well. We have to keep PCP in the back of our minds. Right? Anything else going on? Anything else you observed in the narrator?
Dissociative amnesia.
Clearly dissociative amnesia. Now, there's two variants here, with or without fugue. Number one is, what is fugue, or what is a fugue state? And number two, is there any evidence of it in this film?
Yes.
So there is evidence, and what is it?
It's the Walter White cancer treatment when he kind of generally start wandering somewhere, and you don't really, when you get kind of aroused from whatever condition you're in, you don't really remember where you've kind of just been straying to. That's what, Walter White's malingering, but that's that's the depiction of it.
Traveling.
Yeah, exactly. There's got to be some evidence of travel, usually away from work or home. It is seemingly purposeful, right? So especially when absent confusion, where an individual then assumes a new identity, right? Which, spoiler alert, the answer is yes. So it looks like we have a character that is demonstrating aspects of depersonalization / derealization, as well as dissociative amnesia with fugue. So right now, what are you putting on the chart? What is the single best answer? And the
DID?
no, not yet. From the information we've already discussed, what's our single best answer?
Substance use?
Well, we have to keep that in the back of our mind. But let's say we did investigate that, hypothetically ruled it out.
Like,
Individual with elements of depersonalization, as well as some derealization, evidence of dissociative amnesia with fugue. Single best answer.
Depersonalization, derealization.
Exactly right. The acknowledging that, let me backtrack. It's the opposite. the observation that individuals with dissociative amnesia, with or without fugue, incorporate aspects of depersonalization, derealization. Right? So a single answer would be dissociative amnesia. Okay. So that's operating as our single best answer, as long as we do rule out the direct physiologic effects of a substance. All right. What else?
Well, I guess kind of almost like turning a blind eye to some of the previous discussion, like just with the violence in general, you could consider like antisocial personality disorder.
Yeah.
But if you're, obviously you'd be considering, if that substance induced or not.
Yeah, substances might play a role there too. People sometimes are bigger jerks when they're drinking than otherwise. The quote-unquote mean drunk. So that's always going to be in play. However, we see this film and certainly can interpret and agree upon there does appear to be a cardinal trait of a blatant disregard for and violation of others' rights. And that is the definition of antisocial personality. From that cardinal trait, the individual must demonstrate that as evidenced by, and then they list the criteria. But all those criteria are examples of that cardinal trait. A cardinal trait that our main character, or plural characters, definitely demonstrate. So antisocial personality would be in our differential diagnosis. However, right now it's fairly low because we would have to tease out whether or not that behavior truly is a separate illness or is perhaps part of a larger illness. One of the illnesses that we've already discussed, including substance use disorder. Anything else?
Visual hallucinations. Like
Visual hallucinations.
he sees Tyler.
Do you think he sees him? That's a matter of perspective. There's no right answer here. But if he does see him, might that inform anything we discussed? What are visual hallucinations usually the manifestation of?
Schizophrenia.
Oh, drug use.
Drug use.
Yeah, it's usually an organic pathology, schizophrenia versus general medical condition. So if you are watching this movie and you believe that he actually does see Tyler Durden and that this film, Nightclub, is a fictional case presentation of visual hallucinations, all of a sudden, the idea of PCP being part of the conversation gains more traction. All of a sudden, we may have to kind of revisit the idea of an underlying medical condition as well. By the way, what medical condition would be high on our list here?
Could be like a thyroid issue. Brain tumor.
That would be high, yeah. Personality change, where's the brain tumor going to be located?
Frontal.
Yeah, that's a very common shelf board question. Yep. Frontal lobe tumor. So CT scan for our patient here, especially if we think that he sees Tyler and is experiencing visual hallucinations. Absolutely, right? And that buys him that CT scan, and let's take a close look at that frontal lobe, especially since there's new onset personality change. Good.
Yeah, I also thought it was interesting, like when they were towards like the end of the movie, when when it became like more like Project Mayhem, everyone in the house except for him and Tyler were all wearing black, and so it's just like that's when I also was questioning like these people can't be real. Like it was, I don't know, because like it was my first time watching Fight Club, so it was just like kind of putting it together. I was like definitely like I think he's like either hallucinating or imagining these people.
Yeah. I want to talk about that actually a little bit here. Any other observations or questions about anything we've discussed already?
Kind of going back a little bit, but just with the we were talking about kind of going to these different clubs or like meetings where he was, there was like an AIDS group, tested for cancer. Would you almost characterize that as like a fictitious disorder, like wanting to assume the sick role, or
Could be.
kind of struggling to parse that out a little bit?
Yeah, and there's no way we can unless we ask the narrator here. I'd love to have him just for an hour and ask what he was getting from this. Now, the question is not going to get an answer and all of a sudden everything's perfect. We're probably going to have some sessions here, but understanding the gain that is motivation will help us parse out whether or not there's a fictitious component to his behavior, is fulfilling that sick role, somehow resulting in his, I think his own words were, slept like a baby. Because boy, is it spontaneous.
I thought it was also interesting, like the way when he runs, he discovers Marla, and how her doing the same thing triggered that kind of like response where he's like he didn't know how to handle himself when he was like not the only one that was when like he felt like his cover was blown essentially because like she was doing the same thing.
Mm-hmm.
Yeah.
Yeah. And specifically asked her not to bring things up with Tyler to disclose everything, right? Mm-hmm. Right. Which kind of gets to the next part of our conversation, and that is, let's first put a bow on our differential diagnosis, because there's one other illness that we have to consider here. It was mentioned before. Schizophrenia, or another one. DID.
Oh, yeah.
Right? DID. In DID, we're an individual largely the product of trauma. And certainly the highest risk would be from early childhood sexual trauma. Has their hypothalamus create a state of mind, an altered state of consciousness, where a personality develops to experience and process their immediate threatening environment so as to keep the individual safe and knowledge-free of likely molestation. So the individual may have a part of themselves and their brain detach clear, where now they have what is often referred to as an alter. And the alter's name here is Tyler. Now, we don't know the prequel. I don't know the trauma. But I do know that he first meets Tyler Durden where?
On the
On the
airplane.
plane.
Yeah. Right? And we do see a flashback, although we think it's him imagining, so we're not really sure. Remember the beginning of the movie? What may have happened to this narrator?
The apartment explosion?
Well, that's part of it too, yeah. But what may have happened? He actually, I think, presents it as a wish fulfillment. That he imagines this every time he takes off.
Like the
Yeah,
plane
crashing.
blowing
Yeah.
up.
But that might actually be a memory. Right? So there's some linking to that past event, to that past experience, and the discovery of Tyler. Right? So Tyler Durden may have come into existence earlier on and has now resurfaced because of his getting back on that plane, perhaps for the first time. Closes his eyes and he sees the original crash. Right? Flashback. Now, the other part of this is apartment blowing up. That is stimulus generalization. The plane blew up. But the apartment blowing up rekindled that part of the pun. Rekindled that memory. So there's some more going on here. Of course, post-traumatic stress disorder now is part of the conversation. That is linked to the DID, that trauma. Right? So the trauma causes both. And the literature does support the co-occurring, the high comorbidity between DID and PTSD. Very high, 80+%. All right. Any other thoughts about any of the above? If an individual presents with an altered state that takes over the conscious awareness, there's a distinct personality state and evidence of dissociative amnesia and evidence of depersonalization and evidence of derealization. Single best answer?
DID.
DID, yeah. Because DID incorporates everything. All of the above.
And in DID, you can't have different personality states interact with each other, right?
Usually not, no. It's no. No. By definition, they don't know each other. Now, again, this not only is somewhat controversial, but it is so exceedingly rare that to have an overall no be uniform we have to tread carefully there. So the answer is no, but with a little bit of an asterisk. Anything else? Let's get back to that plane scene, because I think that it's integral in understanding the film. How does he meet Tyler?
They are sitting next to each other.
Yeah, they are.
Like after the flashback that he has.
Yeah.
it was like a woman that was like sitting next to him, and then when he like wakes up or something, it's Tyler.
Tyler. There's a conversation, and how does that conversation end? How does the scene end? And the real trick question is, and this is not going to come up on your board exam, but you'll still impress me nonetheless. How does the ending of the scene allow us to maybe pinpoint when the initial trauma occurred? When that plane crash actually occurred?
During turbulence.
How does the scene end? Doesn't Tyler get up?
Oh, he gets up here with his briefcase and like he walks down the aisle, and then
But could he have been the one to cause the plane to crash?
May have. He could have. How does he get to the aisle? Because you told me he's sitting at the window.
Next to the window,
Yeah. Here's the aisle. Oh,
I don't
No.
remember what happens. Does he crawl over? Or he
No.
just appears in the aisle.
He tells him he's got to go to the bathroom. I won't use the actual vocabulary. And then as he gets to the end of the row, I'm going to paraphrase, states, what will it be? Crotch or crack? Right? Remember that scene?
Oh, yeah.
What is he talking about there?
Like if the narrator's gonna get up, he's gonna walk behind him, or just step over him, right?
Right? Gender assignment. He turns his back on him. The narrator from that point on is quote unquote crack, gynae. This is now Jungian psychology. Right? This is the anima versus the animus. Because the hyper male, the crotch, will remain Tyler. And now this is a battle between two entities within a single person that Carl Gustav Jung referred to as the animus, the male part of all of us, and the anima. That's what this movie's really about. Right? When does that actual battle, identity, occur in childhood development per Erik Erikson? Identity versus role confusion. Remember those 8 stages?
oh yeah.
So now we're linking Jungian theory to Ericksonian theory to pinpoint the time that the trauma occurred.
Like young adulthood?
I think younger.
Younger.
Like
Yeah.
3 or 4.
Adolescence.
Uh,
Adolescence. And it was during adolescence that our main character, that the narrator, likely was in a plane crash. Because he's never resolved his identity issues. What will it be, crotch or crack? And that's a clear battle for him, because he battles Tyler the entire film. Although we don't know that until the end. That's actually his internal battle. The internal, the subconscious, in Jungian psychology being the animus versus the anima. So, an intro to basic Jungian psychology, an intro to basic Ericksonian psychology, review of the dissociative disorders, review of medications that may induce dissociation, and a brief reference to post-traumatic stress disorder as well. Is there anything else? Oh, by the way, yeah, I'm sorry, sleep medicine. Is there anything else that we can pull from Fight Club? By the way, we're breaking the first 2 rules right now.
Coping mechanisms?
Coping? What do you got? What do you have for coping?
Well, I mean, it feels like he's sort of like acting out as a response to his sort of like apathy and like, yeah, hopelessness in life.
So the idea of coping mechanisms, we'll call these defense mechanisms. Now we're adding in now Freudian psychology as well. Defense mechanisms, including acting out. So what's happening here is that you have an impulse. We'll call that warehouse Tyler. People who prefer psychology to Fight Club will call it the id. The impulse is yearning for conscious expression. Can't happen because these impulses are taboo. And a lot of people want to take down the financial district with a series of bombs. but won't. And that's because a second component of our subconscious called the superego, or if you're more inclined to think of terminology in accordance with Fight Club, the narrator, is societal's prohibitions. Conflict. Conflict causes friction, and Freud named this friction anxiety. So in this way, not only can we look at Fight Club and interpret Fight Club as a case study of anxiety, but now perhaps anxiety-induced insomnia, which, again, significant comorbidity. Now, one way in which we all alleviate that anxiety to keep it sub-threshold is through that third and final component of our subconscious called the ego, specifically the ego defense mechanisms, these coping strategies we have. And there's multiple of them, one of which is acting out. Again, the idea here is that the defense mechanism, the role of the ego in general, is to reduce the friction caused by what we want to do, our id/Tyler Durden, versus and in conflict with our superego/narrator. And if somebody employs, for instance, acting out, which is defined as the defense mechanism characterized by an observable behavior on a subconscious impulse, they are likely to have personality variables of assaultiveness, etc. And that's even without PCP. So you talked about antisocial personality disorder already, but now you just introduced a possible etiology of it, because Freudian theory states that the etiology or cause of antisocial personality is the maladaptive defense of acting out. So it comes full circle. Any final observations? Okay, we'll leave it here with one final thought, and that is this film, while I think great to introduce multiple aspects of psychopathology, again, sleep medicine, dissociative disorders, etc., is actually not in our psychopathology seminar in our residency. Of all things, it happens to be in our psychopharm seminar, because it does allow for the use of, or the discussion of, a class of medications called hypnotics, which are sleep meds, which are medications that have been FDA approved to treat insomnia. There are 3 sleep meds that can cause dissociation. So although our minds quickly went to the hallucinogens, and more specifically the dissociatives, the fact is prescribed medications can do this as well. And there are 3 that can induce them. Anybody know what the 3 are?
Are these the ones that-
Ketamine?
Huh?
Ketamine?
No. Ketamine is FDA approved for the treatment of treatment-resistant depression, but not insomnia.
I'm thinking like Zolpidem, Romeltion, and what's the third one?
So, another Z.
Yeah, it is another thing.
Yeah, it's Ambien, right? People, as a side effect of Ambien, you could act like our narrator. Okay. Lunesta and Sonata. Those are the 3 brand names that actually, as a side effect, as a black box warning, can make you act like our narrator. Now we'll stop it there. There's more to discuss pertaining to the psychopharmacology aspect of this, but I think that's enough because it lends to where we started this discussion, and that as we have to rule out organicity. And if we really do believe that Tyler has visual hallucinations, boy, not only are we going to get a CT scan to look at a frontal lobe tumor, especially with new onset personality change, but the role of drugs, not only PCP, urine drug screen, but also prescription drugs, 3 of which have black box warning for behavior that Fight Club is really about. So I think our final thought would be actually prescribe him something after all. And is therefore Fight Club a case of not only insomnia and other, but more specifically an untoward side effect of one of those FDA-approved medications? That's what I think. Any final questions? All right, we're going to stop it here.